Hello everyone, let us discuss about DKA, diabetic ketoacidosis. We will discuss the management of diabetic ketoacidosis. Biochemically, when pH is less than 7.3, bicarbonate less than 15, and serum glucose more than 300 mg per deciliter, we call it DKA. Regarding the management, we have fluid, electrolyte, insulin, sodium bicarb, and precipitating factors. Let's discuss one by one. Fluid. Fluid is given in diabetic ketoacidosis for treating the dehydration. The ideal fluid of choice is normal saline, 0.9% normal saline. We can give Ringer's lactate, but ideal is normal saline. If hypernatremia or HHS, we can shift to 0.45% normal saline. It is given about 5 to 6 liter in 24 hours or 100 ml per kg. But in HHS, we should give around 8 to 10 liter in 24 hours. We can give first liter in 30 minutes, second liter in 1 hour, third liter in 2 hours, fourth liter in 2 to 4 hours, and remaining 2 liters in remaining 24 hours. But if the blood sugar is less than 250 mg per deciliter, we should shift to 5% dextrose to prevent hypoglycemia. But when to stop? We should continue till resolution. What is resolution? Resolution means when the blood glucose is less than 200 mg per deciliter and two of the following with if patient can take orally. pH less more than 7.3, bicarbonate more than 15 and anion gap less than 12. Now let's see the second electrolyte. Most common electrolyte imbalance in diabetic ketoacidosis is potassium, but we should check for sodium as well. If the potassium is less than 3.5, then we should not give insulin because it causes shift hypokalemia and drastic reductions in potassium. If it is 3.5 to 5.2, we should give 10 equivalents per hour KCl IV. If it is less than 3.5, we should give KCl 40 milliequivalent per hour. If it is more than 5.2, it is not needed. The target should be 4 to 5.2 millimole per liter potassium. Next we see is sodium. Generally, there is pseudo hyponatremia or dilutional hyponatremia in DKA. We know for every 100 mg per deciliter rise in serum glucose, sodium drops by 1.6. Or we can use the formula to calculate corrected sodium as corrected sodium equals to measured sodium plus 1.6 into serum glucose minus 100 by 100. But if we see hypernatremia in DKA, then it denotes severe dehydration. The fluid should be more in this patient. Now next one is insulin. Insulins can be given either bolus or infusion. We have insulin. We can give insulin as per the Delta protocols. Delta protocol is quite difficult and it is not available in all the places. It can be given bolus 0.1 unit per kg or infusion 0.1 unit per kg per hour. The target drop of serum glucose should be 50 to 75 mg per deciliter per hour. Rapid corrections of hyperglycemia more than 100 mg per deciliter per hour causes risks of osmotic encephalopathy and cerebral edema in children. Now we can give insulin. We should give IV insulin, like regular insulin can be given 50 units dissolved in 50 ml normal saline. For example, there is a person with 70 kg body weight. We should give 0.1 unit per kg. It is 7 unit initially bolus, and his blood sugar is 700. So we should start with 7 units for first hours, and we should check again after 1 hour. If it is 600, then we can give 6 units per hour. If 500, 5 units per hour. If 400, 4 units per hour. If 300, 3 units per hour. If 200, 2 units per hour. But if the drop there is no any drop. If it is still high or same, then we should double the dose. Like from 7 we should go to 14 units, from 6 we should go to 12, from 5 10, 4 to 8, 3 to 6, 2 to 4. If same or high, we should double the dose. This we should remember. And when to shift to subcutaneously insulin. Once the patient can eat, we can shift to subcutaneous insulin. 2 to 4 hours of overlap should be made during between the infusions and subcutaneous injections. The dose is 0.5 units per kg per day, 50% basal and 50% bolus. For example, if the person is 60 kg and 50% means 30 units will be given basal at night, and bolus 15 should be given at bolus before breakfast, before lunch, and before dinner. 5 5 5, dividing in 3. Now we have sodium bicarb. Sodium bicarbonate should be corrected if pH is still 7.0 after corrections of fluid and insulin. We can give sodium bicarb 50 millimole in 200 ml of the sterile water with 10 milliequivalents per liter of KCl per hour. Once it is more than 7, we can stop. And we should treat other precipitating factors like infection. We should check for CT scan and ECG to check MI and stroke. We should check drug history. We should rule out pregnancy. There might be pancreatitis due to abdominal pain. And we should check all serum lipase, amylase, all should be checked. Okay, thank you.